Hello, everyone. My name is Alicia Krieger, and I am a clinical pharmacist and a researcher on the HIV field concerning trans people, as well as the hormone therapy to transgender people. I'm also the current president of the Brazilian Professional Association for Transgender Health. And now, please let me introduce our next session that is called Hormones and ARVs. This is an extremely important session. The session addresses important issues about use of hormones among trans people using antiretrovirals, whether for treatment or prevention, such as PrEP and PEP. Many trans people and also many healthcare providers are afraid to use hormones in conjunction with ARVs for fear of drug-to-drug interactions, adherence to both treatments, and also the psychological and social well-being of these people. These fears end up turning trans people away from healthcare services. The sessions will focus on addressing the most recent evidence on the use of ARVs and hormones together in trans people, in complex safety and aiming the satisfaction and effectiveness of their use to promote a better life for trans people. If you have any questions or interventions, you could submit them through the Q&A box in the right side. So let me introduce our first speaker, who is Dr. Madeleine Deutsch. Dr. Deutsch is a medical director of the UCSF Transgender Care and an associate professor of clinical family and community medicine at the University of California, San Francisco. She has several active research projects, including study of collection of SOGI data in clinical settings, and study implementation of PrEP in transgender populations, including potential hormone-related drug interactions. She has cared for more than 2,000 transgender people since 2007 and has more than 30 peer-reviewed publications, which is on the board of the United States Professional Association for Transgender Health. Please, Dr. Deutsch, it will be a great pleasure to hear you.
Hello, thank you. It is an honor to present at this session with such a great team of co-presenters and colleagues. I'm going to speak specifically about approaches to hormone therapy. I don't have any disclosures. Pretty much everything that we use in this field is off-label with regards to US FDA approval. All of the medications that I will discuss are approved for use in the US, but for other purposes. An overview of what we'll talk about in this very brief talk. A general approach to hormone therapy. We'll discuss approaches to guidelines, as well as both feminizing and masculinizing hormone regimens, some talk about risks, as well as cardiovascular considerations. So when you are thinking about starting somebody on hormone therapy, I have some general philosophies that I like to follow. I don't really get wrapped up too much in what the person's gender identity is. I think it's important to understand someone's gender identity, but many people have a hormone goal or a set of goals relating to their physical transition that may not even be aligned with their gender identity. For example, somebody who identifies as female may say, I actually would like to have less than the maximal effect of feminizing hormones because that's what I want. Someone who identifies on the masculine spectrum as non-binary, but maybe not as male on a binary spectrum, may say, I would like to have the maximal amount of masculinizing effect that is medically appropriate. Or they may not say that, but that would be the framework in which I would try to take a history and figure out exactly what they want. And it's very individual and based on goals. It really is not based on identity. I like to ask about patients' short and long-term goals. Do they want to get started on a usual start pathway, or do they want to get started somewhat quickly? And then I try to speak with patients about realistic expectations. You cannot dial a hormone, so to say. You can't say, I want lots of facial hair, but I don't want my voice to change. I would like breast development, but I want to retain all of my erectile function. these states of affairs can't always be attained with hormone therapy. And a lot of what happens when someone takes hormone therapy is really to be determined. Everybody responds differently. And I try to keep patients open-minded about this. I like to use a truly informed consent approach, which does not mean hormones on demand, but means having a truly informed discussion with the patient about their goals and expectations, alternatives, options, making sure that it's the right time for them to start hormone therapy, and then I begin hormone therapy. I don't require any formal mental health assessment before doing so. It is not required to do so, but I do have an informed discussion with the patient. What standards or guidelines should you use if you want to follow something or if you need guidance when starting hormone therapy? There are several out there. The reality is that Endocrine Society guidelines, UCSF guidelines, standards of care from WPATH, Callan-Lord guidelines, other guidelines you might find are out there. These are 4 that I feel really solid about. They have a lot more in common than they differ, and you really can't go wrong. I would pick one that you're most comfortable with. The standards of care as they currently exist don't get into too much detail about hormone dosing and tables of doses, etc. So you might find these other 3 guidelines more useful if you want to have a table of how many milligrams should I start someone on, because in this very brief talk, I'm not even going to get into that. Callan-Lord may be a bit more oriented towards community or lower resource settings. Endocrine Society guidelines are a bit more involved and maybe more appropriate for academic settings. They tend to recommend more frequent lab tests and a little bit more. UCSF guidelines are probably somewhere in the middle. You can review these. I think if you choose any of these, you're not going to go wrong. My general approach, this is one slide I just want to show you on my philosophy to hormone therapy. The purpose of this slide is to show you that people with complete androgen insensitivity, these are not trans people, these are people with complete AIS. They have male range testosterone levels, but their body cannot receive the testosterone message because they don't have the testosterone receptor function. So they effectively have 0 testosterone, but you'll notice that they also have male range estrogen levels. And people with CAIS do develop phenotypically as female. They do run into trouble at puberty because they don't go through puberty because they have very low estrogen levels. But the point being is that my general approach in hormone therapy is to target testosterone levels in the range that's congruent with the patient's goals. So the patient wants maximum feminizing effect. My primary goal is getting their testosterone into the female range and then replacing it with a physiologic dose of estrogen as guided by level monitoring. I don't get too much into the weeds of where exactly should your hormone level be once you're in the physiologic range. There is some art to that it's probably can't get into in this talk, but my approach does not involve overdosing people, getting hyped the super physiologic with estrogen or testosterone levels. And I do believe in checking levels, both to make sure you're not getting super physiologic, but also equally important to make sure you are hitting the target. I want to know that I'm suppressing somebody's testosterone fully if that's what they want. And it also can be very engaging for the patient to see their lab results. It can help with adherence, and it can make them feel more engaged and aware of what's going on in their body. So I like to share lab results with patients as well. So clinical endpoints for patients seeking a quote unquote binary transition or otherwise maximal medically appropriate effects. For trans women, I target the testosterone in the female range and add back the estrogen, as I just mentioned. Testosterone, target the testosterone male in the male range. I don't really worry about the estrogen too much. And for people who have a non-binary outcome goal, you really just kind of make your best guess at first, and then monitor labs, discuss the patient. I monitor for changing goals over time. There is some more to it than just making a best guess, but we just don't have enough time to get into that today, but I wanted to map that out for you. So the general approach to feminizing hormones, I use a combination of an estrogen and an androgen blocker, which is usually spironolactone. Sometimes you use a progestogen. There's a lot of debate around the role of progestogens. Can't really get into that here, but it is reasonable to try it after the patient has been stabilized on their initial regimen and their hormone levels are in the target range. Some people say progesterone makes them feel a little better, gives them a libido kick. Other people say it makes their mood worse and it can cause some weight gain. Generally, I use only 17-beta estradiol. There are a number of drawbacks to using ethinyl estradiol. It's very thrombogenic. with regards to conjugated equine estrogens, I don't use those because there are significant ethical considerations in making that medication. It's obtained from horses that are kept pregnant and catheterized. A couple of considerations come up in the context of feminizing hormone therapy. People who are smoking, smoking in the setting of estrogen use of any kind is a risk factor for VTE. We'll talk about VTE in a moment, but if the patient is unwilling or unable to quit, I do take a harm reduction approach. Transdermal estradiol has little or possibly no increased risk of blood clots in the context of tobacco use. Because of the way that it's processed by the body, it does not go through first pass metabolism where it can cause a clotting factor imbalance. So I will steer the patient towards that. I do not routinely put patients on aspirin unless I'm specifically concerned about a very clear risk, maybe a smoker who is going to be on oral estrogen, because there is a non-trivial risk of hemorrhage associated with aspirin. So the old days of putting everybody on aspirin without any care in the world really is over. And I don't use aspirin unless there's a very specific and clear indication, either by a cardiovascular assessment, or if there's somebody, again, who's very high risk for blood clots and you're taking a harm reduction approach. Using estrogens perioperatively, there's a lot of people who say, oh, you have to stop your estrogen for 6 weeks before surgery or 2 weeks before surgery. This is a big topic that I don't want to get too into here, but there's really no clear evidence that trans women of average risk should stop hormone therapy. Perioperative oral contraception studies have mixed results, and there's some methodologic limitations. The truth is that most professional societies don't recommend the stopping of other kinds of hormones, menopause or contraception. So there's really no reason to think that we should be stopping feminizing hormones perioperatively. And you can actually make people go through menopause right at a time that they're going to major surgery, and that's not great. Venous thromboembolism, the menopause data shows that there's no increased risk in a general population when transdermal estradiol is used. The risk may go 2 to 4-fold increase when using oral estradiol, but with the background rate being so low that it's still 2 to 4 times a very low number. And this is not to say that it's zero. And also menopause data does not necessarily directly translate because there's short-term use of maybe lower doses. However, generally, the problem of blood clots in trans women taking feminizing hormones is a solution in search of a problem. Data on this from more than 10 years ago showed 20 to 40-fold increase, but they were using up to 200 micrograms a day of ethinyl estradiol, which I mentioned is very thrombogenic. And they did not control for tobacco use in those studies. More recent data, including a large retrospective Dutch sample, did not find an increased risk of blood clots when transdermal 17-beta estradiol was used. Masculinizing hormones, the general approach, use one of several forms of parenteral testosterone. There is a brand new oral testosterone undecanoate that's available here in the US that can be considered. There's a black box warning on it about hypertension. The data behind that is actually not that great, but I did want to put that out there. It's just brand new. There are some other adjuncts that sometimes use that are really, you can't get into in this talk, but you can find out more about them looking in the various guidelines that exist. But generally the goal is for complete replacement. For those of you who are working in HIV care and are familiar with replacing androgens in cis men who have low testosterone, you have to give complete replacement for transmasculine people. So your dosing and your may be higher and your intervals may be more frequent. Sometimes people get concerned about coexisting metabolic disorders like metabolic syndrome or obesity, dyslipidemia, etc. People get concerned about these in both trans feminine and transmasculine people. The reality is that people may often have improvement in their overall health because they're taking better care of themselves when they start taking hormone therapy because they just feel better about themselves. Things like PCOS, not a contraindication to testosterone therapy. I hear people ask about this sometimes, but it's just not the case. If somebody comes in and they're amenorrheic and they're taking testosterone, so say they're new patient to you, they've been on T for 2 years, they haven't had a period, generally represents atrophy. You don't have to worry about them becoming hyperplastic based on available data. Acne, you take a similar approach to that in cis people. tends to peak in the first year and then declines. By avoiding superphysiologic levels, including avoiding excessive peaks associated with prolonged dosing intervals, you can avoid acne, as well as avoid problems with erythrocytosis by keeping the levels physiologic and dosing weekly rather than biweekly. I mentioned this, so I'll just kind of hammer it home again, that the psychosocial benefits of taking hormone therapy may include positive lifestyle changes that can reduce various health issues, and the benefits often outweigh any potential increased risk. So I'm going to very briefly, in the last 2 minutes we have, touch on coronary artery disease considerations, thinking about all these different factors when thinking about cardiovascular risk in trans people. Right off the bat, there's a calculator that you're supposed to use to calculate somebody's risk. In this particular one, I use the AHA. In any case, there's always a desire to figure out if the person is male or female when calculating the score. You can't always do that because maybe somebody's they're 52 years old and they've only been on hormones 3 years. Which one should you choose? So I tend to do both and then find some kind of weighted average depending on how long they've been on hormones, how old are they, and truthfully, the differences are fairly small between the groups usually. I'm going to briefly show you data from one study and then we'll wrap up. This was a large case, a matching study from a retrospective cohort study from 2 Kaiser sites, thousands of patients, 10-to-1 matching of trans people to cis male and cis female controls. I'm going to skip the demographic discussion and just put that slide there for a moment. Very briefly, not going to get into all the details here. Ignore the lower box because we just didn't have time to get into that. But in an overall cohort of trans women, several thousand, everything that I highlighted in yellow is statistically significant increase. So you can see that trans women were more likely compared to both cis men and women to have blood clot, and then they were increased risk of stroke and MI compared to cis women, but not cis men. Now, you can take from that what you will, but the number needed to harm is very high. So the risk is actually very low, even though there's statistically significant hazard ratio increases. The number needed to harm is very high. In the last slide, for transmasculine people in this study, there was no statistically significant difference between any group and any outcome. And that is reassuring, and that is data we've seen in other studies of transmasculine people. Thank you for coming with me on this 15-minute whirlwind tour of hormone therapy, and I hope you enjoy the rest of the conference.
Thank you so much, Dr. Deutsch. It was a really, really great presentation. So now let me introduce our second speaker, who is Dr. Asa Radix. Dr. Radix is the Senior Director of Research and Education at the Colin Lord Community Health Center and a Clinical Associate Professor of Medicine at New York University. Originally from the West Indies, Dr. Radix trained in internal medicine and infectious diseases at the University of Connecticut and obtained postgraduate degrees in epidemiology and public health at Cambridge University. Dr. Radix has over 20 years of experiences providing HIV care, primary care, and hormone therapy for transgender and gender non-binary people, and is a recognized expert in transgender medicine. Please, Dr. Radix, it will be also a pleasure to hear you now. Thanks.
Thank you for the invitation to speak today about gender-affirming hormones and antiretroviral therapy. I have no conflicts of interest. So first, I'll be talking a little bit about antiretrovirals and gender-affirming hormone therapy, really discussing what the guidelines say, then talking about pharmacokinetics and drug-drug interactions with ARVs and whether there's cause for concern. And lastly, I'll discuss very briefly beyond drug-drug interactions, some issues that you should be aware of as far as lipids, bone health, and cardiovascular disease. So to provide a historical perspective, there's not a great deal of guidance in this area from the transgender health guidelines, despite the fact that transgender communities are disproportionately affected by HIV. The first WPATH guidelines, called HABIGDA, were released in the pre-AIDS era in 1979, just 2 years before the first first case report of a person living with HIV in the United States. In the WPATH standards of care version 6 were actually the first guidelines that discussed HIV and basically said that it was unethical to deny availability or eligibility for hormone therapy solely on the basis of HIV. The United States HHS adult ART guidelines included gender-affirming hormone interactions and ART in 2017. And then most recently in 2019, actually included a complete section on transgender people and HIV. Now, as Dr. Deutsch has pointed out, there are multiple estrogens and androgen blockers used throughout the world for feminizing therapy. And some of these are not recommended, for example, ethinyl estradiol and conjugated estrogens, but they're used in many countries if that's all that's available. For example, in the Caribbean, many transgender women are using birth control pills or ethinyl estradiol along with sapropterin. There are also many different options for testosterone, as you can see, including patches, gels, nasal spray, long-acting injection, and tablets. So this slide shows the metabolism of estrogens and testosterone. The reason for concern about drug-drug interactions is that the metabolism of estrogens mainly occurs in the liver. The first step in the metabolism of estrogens is hydroxylation catalyzed by cytochrome P450 or CYP enzymes, including CYP3A4. And, this is, again, slightly of concern because many of the antiretroviral agents, including the boosted protease inhibitors, ritonavir, cobicistat, and the NNRTIs, are metabolized through CYP3A4, and they elicit variable effects on other medications, acting as either inducers or inhibitors of drugs metabolized by CYP. When we look at the international ART guidelines, most of them include the same antiretrovirals as first-line agents, including a non-nucleoside or non-nucleotide backbone with an integrase inhibitor. If patients are using these regimens, then drug-drug interactions are unlikely to occur. To delve into the ART hormone drug-drug interactions a little more deeply, the ARVs that have the least potential to impact gender-affirming hormones include the NRTIs, the HIV entry inhibitors, for example, IBA, T20, and Maraviroc, unboosted integrase inhibitors, and two of the NNRTIs, rilpivirine and doravirine. When using these agents, no dose adjustment of hormones is necessary. Some of the ARVs can increase concentrations of some gender-affirming treatment. Elvitegravir, cobicistat, and boosted protease inhibitors can increase dutasteride, finasteride, and testosterone. And the recommendation here is to monitor for adverse effects and decrease the doses of gender-affirming treatment as needed to achieve the desired clinical effects and hormone concentrations. There are also some antiretroviral drugs that can decrease the concentrations of gender-affirming treatment. For example, the boosted protease inhibitors, as well as efavirenz, etravirine, and nevirapine, can decrease levels of estradiol. And efavirenz, etravirine, and nevirapine can also decrease testosterone and the 5-alpha reductase agents. And the recommendation here again is to monitor for effects and increase the dose of hormones or blockers to achieve the desired clinical effects. There are also some agents that don't have a clear or consistent action on gender-affirming treatment. Elvitegravir with cobicistat and cobicistat-boosted protease inhibitors can increase or decrease estradiol concentrations. And in these situations, it's important to monitor estradiol and adjust the dose to achieve the desired levels and clinical effects. And I should say that these tables come from the US HHS guidelines, and you can access them to get more information. As you may already be aware, hormone therapy can affect lipid levels, impact on bone health, and both of these are areas of concern for people living with HIV. You know, several studies have shown that lipid levels can be affected by estrogen therapy. You know, the studies have been done around the world and include different types of estrogen regimens as well as different types of blockers. So if you look from paper to paper, you may see different results. But in general, estrogens increase triglycerides, but with oral estrogens only. If you're using, for example, transdermal estrogen, there is no change in triglyceride levels. Testosterone used by transmasculine individuals can result in a decrease in HDL cholesterol and can increase triglycerides and LDL. However, the lipids still remain in the desired level, so the clinical significance of these minor changes is unknown. There are also some effects of hormones on risks for venous thromboembolism and cardiovascular disease. So estrogens are associated with increased risk of venous thromboembolism and pulmonary embolism, and this often occurs in the first year of hormone therapy. They usually, women who sustain a DVT, for example, usually have other risk factors, for example, smoking or that they're living with HIV. We also know that ethinyl estradiol carries the highest risk, and this is no longer used in the current regimens. Estrogen has also been shown in a few studies to increase the risk of ischemic stroke. One recent study was done in the United States using patients who were members of Kaiser Permanente. But again, the risk of ischemic stroke happened after many years of being on hormone therapy. There are also inconsistent results around hormones and myocardial infarction because the studies often do not adjust for risk factors such as smoking. A recent study that looked at individuals in the United States using the BRFSS survey found that transgender men had an increased risk of MI compared to both cisgender men and cisgender women. And transgender women had a twofold increase in MI compared to cisgender women, but had the same risk of MI as cisgender men. And these findings were adjusted for age, diabetes, hypertension, lipids, smoking, and exercise. So again, I think the takeaway message is there's still much more research that needs to be done. So bone health is extremely important for people living with HIV, especially for those who've been exposed to tenofovir disoproxil fumarate, or TDF, or those who are smokers. Transgender women have elevated rates of osteopenia compared with cisgender men even before starting hormones, with one study showing a 15% prevalence of osteoporosis and a 32% prevalence of osteopenia compared to lower rates among cisgender men. In the United States, osteoporosis screening is recommended at age 50 for people living with HIV, and with a recommendation to consider screening earlier if there's elevated risk, which also includes those who've had gonadectomy without taking hormones. So transgender people, especially those who've had lower surgery and also gonadectomy, so either oophorectomy or orchiectomy, and who've stopped taking hormones, are at high risk for osteopenia. And in these situations, TAF is preferred to TDF. Other things that providers can do is to inform their patients, optimize bone health, for example, exercise, diet, smoking cessation, and vitamin D. Some of the important benefits of hormones also include improved quality of life, reduced stress, anxiety, and depression, and improved social functioning. Hormones also have a beneficial impact on HIV care and retention. Results from a recent SPRINTS initiative actually showed that integrated HIV care with hormones improved retention and viral suppression. Hormones are also extremely important for getting people into care in the first place. So the key takeaway points are that although there may be small interactions between some ARVs and gender-affirming hormones, the first-line agents used for HIV treatment, the unboosted integrase inhibitor regimens, do not really have any significant effect on hormone levels. Boosted proteases and NNRTIs may influence estradiol, testosterone, finasteride, and dutasteride. It's important to measure hormone levels after initiating or switching ART if a drug-drug interaction is anticipated. And people living with HIV have an elevated cardiovascular disease risk. So in all patients, whether trans or not, we should be addressing modifiable risk factors and paying close attention to ART regimens. For transgender women, we believe that transdermal estrogens are preferred to reduce the risk of venous thromboembolism. And lastly, consider your patient's risk for osteoporosis and osteopenia, and you may consider using a TAF instead of a TDF regimen, and also doing early DEXA screening for patients if they've had gonadectomy, especially if they've stopped hormones or are taking low doses of hormones. So I'd like to thank you for your attention.
Thank you so much, Dr. Radix. It was really a great presentation as well. Thank you so much. And now, let me introduce our last but not less important speaker, Dr. Jay Cevallos. Dr. Cevallos is an associate professor with the Center of AIDS Prevention Studies in the Department of Medicine at University of California, San Francisco, and a licensed clinical psychologist. As co-founder and principal investigator at the UCSF Center of Excellence for Transgender Health, Dr. Cevallos' community-based, federally funded research is focused on leveraging data to develop transgender-specific, trauma-informed programs led by trans communities themselves. Dr. Cevallos' interventions seek to promote sexual health and resilience among transgender people, with an emphasis on serving transgender women of color and those affected by HIV in San Francisco Bay Area and also in São Paulo, Brazil. For their scholarship on transgender health, Dr. Cevallos was recently awarded in 2018 Outstanding Achievement awarded by the Community on Sexual Orientation and Gender Identity of the American Psychological Association. Dr. Cevallos' research and advocacy interests lie at the intersection of health, identity, and social justice. Dr. Cevallos, it will be a pleasure to hear you as well. Thank you so much.
Hi, welcome. I'm Dr. Cevallos, and I'm really happy to be here to talk to you today about hormones and PrEP. The objectives of today's talk are to describe the rates of, barriers to, and facilitators of PrEP uptake among transgender people who are using gender-affirming hormone therapy. We'll also review data regarding PrEP efficacy among transgender people on gender-affirming hormone therapy. And we'll also assess the current data that we have about drug-drug interactions between gender-affirming hormone therapy and PrEP. And as a behavioral scientist, I will be focusing on these objectives rather than doing a deep dive into the pharmacokinetics of hormones and/or PrEP. And throughout the presentation, I will offer resources for those who wish to obtain more detailed information about the pharmacokinetic properties and/or drug-drug interaction studies that I will be referencing. So let's start with what is PrEP? PrEP, as many of you I'm sure know, is pre-exposure prophylaxis for HIV prevention, which was approved for this purpose in 2012. It's a once daily pill that reduces the risk of acquiring HIV from sex by more than 90% and from injection drug use by more than 70%. There are currently 2 medications approved as pre-exposure prophylaxis for HIV, emtricitabine with tenofovir disoproxil fumarate, which is recommended for all adults and adolescents at risk for HIV through sex or injection drug use. And the second medication is emtricitabine with tenofovir alafenamide. And that is recommended for adults and adolescents at risk for HIV through sex, but that excludes people who are at risk through vaginal sex. It has not been tested with folks at risk through vaginal sex, and so you may want to keep that in mind for your patients who were assigned female sex at birth. And of course, PrEP should always be considered part of a comprehensive prevention plan that includes a discussion about the importance of adherence to PrEP, condom use, other sexually transmitted infections, since PrEP does not protect against those, and other risk reduction methods depending on your patient's preference. So first, I'll talk a little bit about the fact that despite high rates of HIV among transgender people, we see low levels of HIV testing and PrEP use among these communities. So this is a study that is, to the best of my knowledge, the first nationally representative sample of HIV negative sexually active transgender people in the United States. And in this study, among 112 respondents who had sex with cisgender men and or transgender women, so were therefore potentially at risk for HIV acquisition, only 5 respondents reported currently taking PrEP. And there was no difference between trans men and trans women in this particular sample. When we look at PrEP familiarity, of 190 respondents who reported being sexually active in the 5 years prior to the study, about 48% of them were familiar with PrEP. And that was about 58% of trans men who were familiar with PrEP, and only 35% of trans women who were familiar with PrEP, who were sexually active in the 5 years prior to the study. The good news is that among those who reported being familiar with PrEP, the majority reported favorable attitudes towards PrEP. So we do see some openness to the idea of PrEP once people are familiar with what PrEP is. We don't know as much about trans men in regard to HIV risk and PrEP uptake, but there have been a couple of studies that have looked at PrEP eligibility rates among trans men and how many of those are actually taking PrEP. So this particular study by Golub and colleagues that was published in 2019 did an online survey with trans men ages 18 to 60 and found that 439 or 24% of those they surveyed were eligible for PrEP based on these criteria. So they were either at risk because of condomless sex or STI history, engaging in sex work, injection drug use, or having multiple cis men or trans women partners in the past year. But of those 439 who were eligible for PrEP, only 10% reported actually being on PrEP, which is lower than we would hope. Another study looking at transgender men, this was also a national online study of 857 trans men who have sex with men specifically. Reisner and colleagues found that 1.6 of those were living with HIV and 52% met PrEP indications, but only 33% reported lifetime PrEP use, with only about 22% reporting current use. Some of the factors associated with PrEP indications among these trans men who reported having sex with men were where they met their sex partners, not having sex exclusively with cisgender men, higher perceived HIV risk, greater number of partners, and high stigma associated with having a cis male partner. A very interesting study of PrEP among Black and Latina transgender women who, Black and Latina transgender women do report the highest rates of HIV and are considered at high risk for HIV acquisition. This was a mixed method study by Petit and colleagues of PrEP engagement among Black and Latina transgender women, which found high PrEP awareness and willingness to take PrEP, but low uptake. So as you can see here, concern about drug interactions with hormone therapy was the most frequently reported barrier to PrEP uptake among those who were not willing to use PrEP. But here, in contrast, you can see that among the women who were actually using PrEP, very few reported experiencing interactions with hormones. And you can see some of these other reasons that people reported not being willing to take PrEP and the rates of actual experiences that women reported while they were on PrEP. In the past 5 years, there have been quite a few studies looking at trans-specific barriers and facilitators to PrEP uptake and adherence. And this is really important because transgender people often get left out of HIV prevention and treatment research, and their unique needs don't end up getting met by the programs that are developed based on the research that does not consider their needs. So some of these unique needs have been explored with various studies looking at facilitators to PrEP, such as integration of hormone therapy and PrEP provision. Now, this is something that is important for healthcare providers to keep in mind, that if it's possible to provide hormone therapy and PrEP from the same provider at the same clinic, this really eliminates a primary barrier for transgender people who often prioritize hormone therapy over HIV prevention, and having to run around to different providers in their city, make multiple doctor's appointments is a real barrier to PrEP uptake. And so if they can be provided by the same provider, that's a real plus for encouraging PrEP uptake and adherence among transgender people. Active provider engagement and assistance around PrEP. So you really want to actively assess your patient's eligibility for PrEP, their interest in PrEP, make sure they're educated about PrEP, and in particular, addressing this one barrier to PrEP, concerns about interactions with hormones. So we really want to educate our patients about the safety of PrEP, and I'll be giving you a little more specific data about that in a bit, but also addressing medical mistrust. We see that many transgender people will avoid healthcare due to past negative experiences and mistrusting the medical system to really be able to care for their unique needs. So the more that you can build trust with your patients and make sure that you're paying attention to some of the unique experiences that transgender people may have, both outside of the healthcare setting and within it, the better we'll be able to make sure that people are getting what they need. And there also have been some unique concerns reported by healthcare providers themselves. Some healthcare providers have reported being hesitant to prescribe PrEP to transgender people because there hasn't been, until recently, good data that indicates the safety of taking PrEP concurrently with gender-affirming hormone therapy. In addition, there has not been any standard of care clinical guidelines for PrEP initiation and monitoring concurrently with gender-affirming hormone therapy. And this has not given healthcare providers the confidence that they need to be able to initiate PrEP with their patients who are also taking gender-affirming hormone therapy. The first randomized control trial that led to the approval of PrEP in 2012 was the IPREX study. IPREX enrolled 2,500 participants from around the world, and in the original publication reported that 29 of those participants were female or identified as female. And the very first publication reported PrEP efficacy in transgender women because they were combined with the men who have sex with men in that study. However, a subsequent subgroup analysis looked at how how participants' gender was categorized in the original study, and found that yes, the original 29 identified as women, but there were an additional 296 that identified as trans based on a checklist that was included in the survey. 14 reported use of feminizing hormones, and so 339 participants reported one or more of these characteristics, which actually enabled a subgroup analysis of the transgender women in the IPREX study. And based on this sub-analysis, no efficacy of PrEP was demonstrated among the subgroup of transgender women on an intention to treat basis. There were 11 infections in the PrEP group and 10 in the placebo group. And using drug level testing compared with MSM, transgender women had less consistent PrEP use. Although there were no seroconversions observed in trans women who had tenofovir diphosphate levels in the blood that were equal to or greater than 4 pills per week. Unfortunately, hormone use in the study was associated with lower tenofovir diphosphate levels, and among the trans women in the study, condomless sex was actually associated with lower PrEP use, as opposed to the men who have sex with men in the iPrEP study who reported higher levels of PrEP use during periods of condomless sex. So we definitely want to see greater adherence among transgender women using PrEP, and also using PrEP when it's appropriate during periods of risk. So recent studies have begun to address this potential drug interaction concern that is often cited by both trans people and healthcare providers alike, who really want confidence in taking PrEP with gender-affirming hormone therapy. Theoretically, drug-drug interactions are not expected between gender-affirming hormone therapy and PrEP. However, among transgender women on gender-affirming hormone therapy, small studies have identified a minor drug-drug interaction between gender-affirming hormone therapy and tenofovir emtricitabine, with tenofovir emtricitabine exposures 12 to 27% lower among transgender women than among cisgender men. The mechanism of these drug-drug interactions is not clear and requires further study. But for some perspective, the median tenofovir emtricitabine concentrations were still within the range of median concentrations reported across controlled pharmacokinetic studies. Therefore, we do believe that the drug concentrations do reach protective levels, and it's not clear what the clinical significance of these lower drug levels are in trans women taking estrogen. There has been one study looking at hormone concentrations in both transgender men and transgender women, both before and after PrEP dosing. And after 4 weeks on PrEP, there was no change in hormone levels, either among transgender men or transgender women, allowing the authors to conclude that PrEP definitively does not impact hormone therapy. And this is a really important piece of information to provide your transgender patients with if they do report concerns about how PrEP might negatively impact their hormone therapy. So some of the takeaway points from these drug-drug interaction and pharmacokinetic studies are that PrEP, tenofovir emtricitabine, does not affect hormone levels in trans people. Serum tenofovir levels are reduced in the presence of estrogen. However, the clinical significance of this reduction is not known, and greater adherence to oral PrEP may be indicated for trans women. So there has been some reluctance to prescribe on-demand dosing or to encourage on-demand dosing among trans women, because we really, for now, want to see trans women taking daily oral PrEP. If you're interested in taking a deeper dive into the pharmacology and drug interactions, I highly recommend this article by Jaeger and Anderson. So to summarize the presentation, PrEP is safe and recommended to prescribe to transgender people on gender-affirming hormone therapy who are at risk for HIV acquisition. Gender-affirming care is essential to PrEP delivery. It's really important that trans people feel safe and able to access their clinical care, knowing that their provider is competent to address their unique needs. We do need more research to inform national guidelines for PrEP indication, and we need to meaningfully include transgender people in PrEP research going forward. Thank you so much.
Thank you so much, Dr. Sevelius, for your great presentation. Now we're going to start our Q&A session between the audience and the presenters. It's a great pleasure to be here today with you. And it's also a great pleasure to be among great colleagues as Jay Values, Asa Radix, Maddie Deutsch, who is coming yearly, and also Aiden. It's a great pleasure to be here with you. As I said, this is an extremely important session, not only in the biomedical aspect, but also in social and cultural aspect as well. Because to prescribe a drug for prevention or treatment is not only to prescribe a drug. You need to think if the person is affordable to buy this drug, for example. That is not common in Brazil because we have a universal coverage of ARVs in our country, but it's not the same in different countries. For example, in the United States, you need to have a health insurance to buy these drugs, and is also a thing that I would like the presenters to share a little bit about the situation, how to buy these drugs in different countries, not only in the United States, but I know that you have researchers in Africa and another countries as well. I would like to thank the presenters as well, Dr. J.C. Values, Dr. Asa Radix, and we have some questions from the audience to you, and I would like to share these questions, okay? Feel free to answer because there is no specific names in the questions. So, Natasha Julian Delgado. Children go to pediatricians and adults see an internist. Pregnant women see OB-GYN. Who exactly do transgender people consider as their primary care providers? Endocrinologists, general pediatricians? What do you think?
Yeah, I can take that question. So I think it really depends on the situation within a country, how the medical system is set up. Where I work, primary care providers are the ones who give that care. So family medicine physicians, general practitioners, internal medicine providers. Of course, endocrinologists can also supply that care. And we've started to see Planned Parenthood and other people working in sexual and reproductive health providing these types of services as well. So I think it's very broad. The WPATH standards of care do not specify the type of provider who is qualified. I think that qualifications you build as you start doing this work. You know, you get more experience. So.
Great. Dr. Values would like to add some comment?
No, I think Dr. Radix covered it. Thanks.
Oh, yeah. I would like one comment because here in Brazil, clinical pharmacists are able to prescribe PrEP and hormones. Not only the medical doctors, the physicians, for example. In Brazil, clinical pharmacists, as me, for example, we can prescribe some drugs. So let's move to the next question. Due to the bureaucracy and not a competent and dignified healthcare system here in Mexico, I have to resort to clandestine hormone therapy. My question is, what are the effects of not taking hormone regularly and only doses of 2 months and then stop for 3 months and then again? And it also gets expensive and unaffordable to get hormones here. Asa, Jay?
Yeah, I mean, I think this is a very good question. What I would say is, it's not a safety issue to use hormones less frequently or in lower doses. But what the impact is that the changes that you'll see, in your body are going to be much, much slower. And if you have too many gaps, you may not really see differences at all. The biggest concern, obviously, is what this impact has on your mental health as you're taking hormones, not being able to take them properly, and then not seeing the changes. Obviously, we do like people to take these agents under kind of supervision because there are blood tests that need to be done. and I think that really covers everything. You know, I'll just say, like, if you're using a medication like spironolactone, it's really important to check the potassium, because elevated potassium levels can impact on the heart. But it sounds as if the real question is about underutilization of hormones rather than just using them outside of medical settings.
Great, Asa. Thank you so much. The next question from Alexandra Rodriguez is, about 1% of population is resistant to HIV infection because of muted CCR5 gene. I think it's to Dr. Asa. Sir, may you please explain this thing and why?
Sorry, I didn't see I'm just trying to read the question now.
I can repeat. About 1% of population is resistant to HIV infection because of muted CCR5 gene.
Yeah. So the issue is that when you have you know, a CCR5 mutation, that the HIV, the virus, doesn't actually connect to the cell because it's connecting to a receptor, and when the receptor has this change, the virus cannot connect. And this is, you know, it's not the only receptor for connecting to the virus, but it's a very important one. So you know, this is why they've been able to use this mutation to an advantage by, you know, for example, in at least 2 cases, people having bone marrow transplants because they had underlying malignancy, and then being able to acquire this beneficial mutation. And hopefully, you know, as we go on with gene therapy and other experimentation, we may find a way to do this more easily. Undergoing chemotherapy and having a bone marrow transplant is not a effective way of curing HIV. So.
Yeah, great, thank you. To Jay's values is a question of mine. Jay, you have experiences researching both in the United States and Brazil. Please talk a little bit about the difference on accessing PrEP. For example, in the United States and Brazil, talking a little bit about the difference on accessing and how to buy, or if they receive PrEP hormones in the different countries. Could you please share a little bit about this?
Sure. I mean, I can speak from my own research experience. I'm not going to cite data off the top of my head, but I can speak to what I've learned conducting research in both settings. In the U.S., there are several drug assistance programs that can help people get access to PrEP if their insurance doesn't cover it. And, you know, with the right kind of navigation to PrEP, we've seen communities that want access to PrEP to be able to get it. It can be complicated. If those programs don't work for people, it can be expensive and difficult to maintain that access. In Brazil, PrEP is on the national formulary. So theoretically, people can get PrEP for free in Brazil, but we see that, again, there's this kind of gap between what's theoretically possible and the actual access that people have on the ground. So we do see fairly low awareness of PrEP, both in the US and Brazil, among some of the most vulnerable communities that we really want to make sure have access to it. So I think that is you know, that's one of our first hurdles, is to make sure that people understand what PrEP is, understand how it might benefit them, and address any potential concerns or questions that they might have about both PrEP use, PrEP adherence, and about maintaining ongoing access. So I think the use of peer navigators has been really successful in several settings within the US and in Brazil. And so that's one of the interventions that we've really been focused a lot on, is building capacity for peer health navigation.
very great to work together with transgender people. I think that's the key message. Very good, Dr. Ceballos. I'm sorry, Alexandra. I've noticed that you said that it was not your question, but I think your question was already responded as well. But I'm sorry for that. So let's move to another question. Dr. Radix, can you elaborate on how you are increasing DEXA scans for patients? Most insurance plans don't pay if a patient is under 40 years old. Do you have some types you can share to help get the scans covered?
Yes, and this is a good question. I mean, I think the issue is that generally insurance companies will follow standard guidelines. And for example, if someone has had a gonadectomy, so for example, removal of the testes, and has stopped taking hormones, then they are at high risk for osteopenia, or low bone mineral density, and you should be able to get it covered. I think it's a matter of using the correct codes and explaining the reason why, because you wouldn't be doing a DEXA scan on a 40-year-old who had no risk factors, right? So you would need to do that.
Very important information. Thank you so much for sharing. Another question is, I think it's to Asa or Dr. Madeline Deutsch, is kindly say more about the nasal spray testosterone. Very interesting.
I have not, that is something that I have not looked into. I know that it's something that is coming available. I don't know much about it because I think it's brand new. There is another kind of recently added form of testosterone available in the US that I've started using just recently, which is a oral testosterone and decanoate. And the medication it is a good alternative. It has a black box warning with regards to risk of hypertension. In my interpretation of the clinical data, there's just not enough clinical risk to really support that black box warning from the FDA, but it is there. The challenges with using the oral form of testosterone is that it does require some degree of titration, and then because of the black box warning, there are some kind of hypertension monitoring requirements, and so I wonder if that might be prohibitive for patients who are having other adherence challenges or linkage to care challenges. And the last thing, again, I just have not read up much on the nasal spray testosterone because I don't even think that it's available yet in the US. I'm not sure if anyone else knows, but these new forms tend to be brand name, and they tend to be very expensive. And many formularies, especially low income and safety net plans, will probably exclude them at least at the outset.
Thank you, Maddie. I can talk about the nasal formulation. It's actually there are a few issues with it. The first thing is that you have to use it 3 times a day. It is FDA approved in the US. I just don't think it's used very often. You have to use it 3 times a day, which is that's a lot to be using a medication. You also can't use it if you are using other nasal medications, especially like nasal decongestants. You can't use it if you have rhinitis or other types of nasal issues. So I do think that it's probably for a very select number of clients, not for everybody. And I think really the frequency of administration would make it a little difficult. I know it's used in Canada by providers there, which is where I first learned about it. And again, in the US, it is FDA approved, but not many people are using it at the moment.
Yeah, thank you for both you for your answers. I think it's not available even in Brazil or Latin American or African. I don't think so. Another question to Jay Ceballos. Jay, any sense of what was unfavorable for the drop-off for transmasculine individuals in the probe sample much larger drop-off? The comment.
Yeah, I'm not sure. I'm not sure I completely understand the question. I think in the probability sample, we did not measure sort of why the drop off happened for trans men in terms of PrEP use. Some qualitative research has shown different reasons that trans men may either not initiate PrEP or not or discontinue PrEP. Various reasons like variability in people's sexual risk. So if people get into monogamous relationships where they don't feel that they're at risk anymore, they may discontinue PrEP. And you know, other various reasons why people may not initiate, which I alluded to, like concerns about interactions with hormone therapy, just not being aware of PrEP, or not having a provider who can work with them with both hormone therapy and PrEP, and just not being, able or willing to sort of navigate the barriers that PrEP initiation can sometimes present.
Okay, thank you. We can extend a little more the Q&A session. It could be a little bit longer. So if you want to send more questions through the Q&A box, please send new questions to our panelists. I have a question to the three panelists. It's concerning the new pathways on PrEP. For example, the injection PrEP, long-term antiretrovirals, for example, using carboplatin, for example. But we have a barrier in transgender women and travestis in Latin America, which is the silicone. I would like you to share your experience on this and how to improve the situation, how to solve the situation. For example, using intradermal, subdermal implants, for example. Could you please share your experiences on this?
I will defer to Asa on some of this, but one thing I will comment on is that there was a study done. I think it was a trans woman who was living with HIV and had a history of silicone. It wasn't really a study; it was a case report. Had a history of silicone injections, and she needed, I forget what it was, enfervatide. I forget exactly what she needed, but the point was that she needed some kind of injection, and they did a ultrasound of her soft tissues to demark where the silicone accumulations were, and were able to identify a area of skin that would be appropriate to inject.
Great. Asa or Jay, would like to add some comments? Can you hear me?
We can hear you. I just don't have anything particular to add. And it looks like Dr. Radix might be having some connectivity issues.
Yeah,
Asa,
yeah.
did you have anything to add?
I think the only other comments I can make about kind of chemoprophylaxis options that don't involve one pill once a day, TDF, FTC delivery is, and actually, Alicia, I mentioned this the other day in our discussion in Rio, is the behavioral aspects of these modalities. I mean, cabotegravir is particularly enticing because the adherence issue is basically eliminated, but you do need to link patients into that service, and that requires a community level uptake and community kind of awareness and comfort with it, and when you have a community that has a lot of stigma in healthcare and is a lot of suspicion about healthcare, there might be some challenges getting uptake with regards to engaging in cabotegravir. Regarding other approaches like 211, I do get concerned about again, adherence and appropriate use, and all the studies on 211 effectiveness have been in MSM communities for the most part, and are looking at, there are community level aspects to adherence and uptake there. People in the community just kind of know about it and just know what to do, and there's a fluency and a familiarity. And in the trans female community, I just don't know that that fluency and familiarity is there, and if that would translate into kind of a as treated analysis, would it have the same effectiveness? And then the last piece is, the jury is still out on whether or not there are some minor interactions between something like, for example, TDF. Now we don't know about TAF, but TDF and hormones that could result in a small window of outliers in trans feminine people having subtherapeutic levels, potentially, which could potentially raise a question of whether the effect size of that clinical impact is higher in people using a 211 approach as opposed to a daily dosing, where we feel that daily dosing in all trans women is safe, but that there may be less forgiveness for number of missed doses per week. And how does that translate into 211 dosing? We just don't know. So I have been hesitant to recommend 211 dosing to all but my most likely to be profoundly adherent trans women.
Asa, are you joining us again?
Yeah, I'm back on. Thank you. I just didn't catch the question at the beginning.
Yeah. I couldn't hear you, sorry.
Can you hear me now?
Yeah.
Okay. No, I'm back on. I missed the question at the beginning. I was having your question went in and out.
Yeah, I would like you to share your experiences and your vision on the new pathways to PrEP and new technologies, for example, injection, intradermal, intra or subdermal implants, for example, and the barriers that trans women that have a lot of silicone injected into their bodies facing with these new technologies, for example, and not the biomedical aspects, as Maddie said, but the behavioral aspects. The HIV combination prevention say that is not only one option to one person. We have a lot of options that we can address to different persons. Could you please talk a little bit about this?
Yes, I think other people have touched on various components. What I will say is, especially for the long-acting cabotegravir, which we're hoping to implement as soon as it's approved in the US, is the real issue that it's not been well studied as in women who've injected a lot of silicone into the buttocks. So I think we'll have to see if it changes efficacy. I think that's the most important thing. The second is, one of the things we know is that women of trans experience are far less likely to have interactions with medical systems where they will be either offered PrEP in any form or undergo the screening for STIs, which also is, where you can get connected to PrEP care by having an STI. But if you never get tested, well, then you miss that connection point. Even when women do have STIs, they're less likely to be linked by their providers to PrEP care. So I think we have to intervene on many levels, the community level, working on improved interactions with providers, improving knowledge with providers about what they need to be doing to keep people in care. I think there are so many different levels for us to work on, that the type of PrEP that's being used, of course, is important, but the offer of PrEP has to be made first of all.
Great. There is a question from Jay to you, Weza, and also for Maddie, for both of you. In your clinical practice, do you see the questions from your trans patients about PrEP evolving as more information gets to community, or are people still concerned about the drug-drug interactions, for example? Are any of you trans patients use 2-1-1 dosing? Yeah, it's a question of mine as well, because, for example, here in Brazil, there is a lot, the great part of trans women are engaged in sex work, for example. So how to imagine, when do I have a risky sex intercurrence, for example? Could you share your opinion, please?
Yeah. As far as the first question, which is about people's concern about PrEP and drug-drug interactions, often people don't offer that as a reason, but it's still something they're concerned about. So we've stopped waiting for people to ask us the question, and we're very proactive in saying, just so you know, this is not a problem. It will not lower your hormone levels, which is really what people want to know. Obviously, talking about that PrEP is going to be effective is also something people want to hear, but really it's a lot about the hormones. So, we've created that. As far as 2-1-1, there are more and more people using 2-1-1. I can't give you an exact breakdown how many folks are trans or not, but what I would say is that for people who are doing sex work, honestly, probably a one pill a day is better, just because if you're doing it on demand and you're having sex, more than, 3 times a week, you're going to be taking it every day. So it just, I think, would make more sense to encourage people who have, um, you know, uh, who are having more interactions where they have sex, that it should be daily. For people who are having sex on a very not as often, because we certainly have people who say, I have sex once a month, like, do I really need to be taking this every day? Well, for folks like that, honestly, the 2-1-1 probably makes the most sense for them.
I, I certainly I certainly see a lot of people who I would love to get on PrEP who are not wanting to be on PrEP yet. And then I see on the other side, I have some people who are on PrEP who probably don't need to be on PrEP, although I don't really, yes, I don't, there may be more to the story that they're not disclosing, but the information that I have, I guess the kind of demographic that I'm talking about is like, the phenotype would be like a 24-year-old engineer who works in Silicon Valley and has commercial insurance, and has a couple of sex partners who live out of town who they see once or twice a year, and then is on Tinder and thinks maybe in a couple months they may want to go on a date. And then that person will say, I want to be on everyday PrEP for extra caution. And I'm thinking that that person would actually be great for either 2-1-1, or I'm not in a season of risk, but I know that next month I'm going to see my partner in Cleveland, so I'm going to start PrEP now for this season of risk. I think that the only thing that those kinds of things bring up to me is that as a kind of health systems person and thinking about population health, are there ways to, thinking about utilization and total cost in the system, and this gets into more kind of health systems analysis, but are there utilization considerations there? And it also brings up actually the injustice and inequities of people who have commercial insurance have access to a wide range of services that may actually be kind of more than they need, and then there are people who are on low income plans who don't have access to the bare minimum of what.
Great, thank you. I just want to point out that we had a technical issue with the Meet the Experts session, and we won't be able to make this session. And we are very sorry for that, but we can have, I think, one or two questions from the audience. So, Aiden, do you have a question? Yes, your question is, are the most important unanswered question about drug-drug interactions or pharmacokinetics, for example. What are the research priorities?
I mean, I think something that, you know, we've talked a bit about several recent studies looking at TDF and estrogen, or TDF and estrogen and testosterone, but obviously TDF is one, you know, a member of one class of medications, and we don't really know about other classes, important classes of medication, other important classes of antiretrovirals, I should say. And you know, we don't even know if some of the kind of marginal differences we've seen in the TDF research translates over to TAF. So I think it'd be interesting, especially with cabotegravir coming down the pike. That seems like really a ripe area for additional investigation.
Isa, Jay, would you like to add some
Yeah.
comments?
Yeah, I think one of the other areas that you know, is important to look into is that there are many different formulations, for example, of hormones, right? And block is used throughout the world, and many of the studies that have been done have looked at, you know, for the most part, agents that provide, you know, very stable, steady state levels. I mean, and again, that's there are newer data coming along that where people have looked at, for example, you know, injectable estradiol, where you have the super physiologic peaks, and sometimes you can have levels that are low. So I think we need more on the many different varieties of hormone combinations that people use, and including the fact that some women are using progesterone within their regimens. We have, you know, many different combinations of use. And I think those all need to be included when we're talking about drug-drug interactions, or at least need to be studied.
Oh, great. Thank you. Would you like someone else to add some comment? Aiden, Jay, someone else? Okay. So I think we need to finish the session, and I'm sorry again, technical issues we had with the media experts. And now I'll talk a little bit about tomorrow's program. Tomorrow at 10 a.m. East, we will have the panel called Surgeries and Body Modification Services. And the talks will be, the first one is surgical body and facial modification with Isabella Ventura. The second one is surgical body and facial modifications with Professor Rodrigo Itocaso Rocha from University of São Paulo in Brazil. And a really good panel talk, I think, that is Love Yourself Despite. And who will talk about this will be Bambi Salcedo. The next panel will be the pleasure engineers, trans people in sex work. The first talk will be health and HIV services for sex workers, service providers perspective with Jacques, I'm sorry if it's wrong, Jacques van der Kolk. And the next talk will be community perspective with Samira Heiken. So we will waiting for you tomorrow. So thank you so much. Thank you to the panelists for your brilliant presentations today. Thank you to Virology Education, IRGT, for the supporting and to organizing the sessions. And I would like to ask the panelists for a takeaway message for us to finish the session. Would you please share a takeaway message with us? Jay, Matt?
I think I would say my first rule of treating transgender people with hormones, including in the context of using antiretrovirals, is to check your own pulse first. Take a deep breath, and generally, this is safe stuff that is helpful for people, and the whatever biomedical risks truly exist in any corner are undoubtedly and overwhelmingly outweighed by the benefits of providing the treatment.
Yeah, and I would also follow on with that, in that the the biggest risk is always not providing PrEP when it's needed. And, unfortunately, that happens far too often. I think for providers, thinking about making every visit and every interaction opportunity to discuss, prevention in all its ways, not only HIV prevention, but also preventive care. I think these are really important tools that can be offered to clients.
Jay, could you give us a takeaway message?
Sure. I think the only thing that I would add is just the importance of really engaging patients in the decision-making processes around both hormones and PrEP, making sure that patients have all the information that they need, get all of their questions answered, and sometimes it might take 1 to 5 sessions before someone's ready to initiate PrEP, but that building that trust and providing that information and making sure patients are collaborators in the decision-making process can go a really long way to building that rapport and to successful kind of interactions. So thank you, Alicia, for your fabulous moderation today.
No, thank you so much. And I would like to share a takeaway message as well, is nothing about us without us, because it was a pleasure to be here with you today, for me as a pharmacist, for me as a healthcare provider, but mainly for me as a transgender woman. It was a panel with 4 and 5, with Aiden, 5 trans persons. All of us are trans persons. I don't know the specific identity of each of you, if are gender no-binary or travesties as me or trans men, but we are all trans, and we are working with trans people. And it's a great pleasure to be here with you. Thank you so much, and nothing about us without us. Thank you so much, and see you tomorrow.